All right, let's jump right into this explainer and see how we can use inflammatory biomarkers to literally revolutionize our approach to canine epilepsy. Look, for all of you veterinary students and future practitioners out there, diagnosing and managing seizures, it's easily one of the most stressful challenges you're going to face in the clinic. But today, we're unpacking some truly groundbreaking data that's going to completely change how you evaluate your neuro patients. We're talking about simple, cost-effective blood tests that basically act like a window right into the brain. So here's our game plan for today. First, the Canine Epilepsy Challenge. Second, neuroinflammation and biomarkers defined. Third, CRP and NLR clinical findings. Fourth, PLR for idiopathic epilepsy. Fifth, shaping therapeutic choices. And finally, references and key takeaways.
All right, part 1, the Canine Epilepsy Challenge.
You know, idiopathic epilepsy is incredibly common. It affects up to 5% of all dogs. But getting the diagnosis, that's really just the start. According to the AKC Canine Health Foundation, a whopping 20 to 35% of epileptic dogs develop drug-resistant epilepsy. I mean, think about that. Our current treatments are failing roughly a third of the time. These poor pups often end up needing multiple anti-seizure meds, which places a massive clinical burden on us and leads to just heart-wrenching outcomes for their families, like cluster seizures, status epilepticus, and, tragically, even epilepsy-related euthanasia. Which leads us to a really critical question for any general practitioner. If our treatments are missing the mark a third of the time, how do we get ahead of the disease before those devastating cluster seizures strike? We desperately need non-invasive tools that give us a sneak peek into the brain, ideally the moment that very first seizure happens. Moving on to part 2, neuroinflammation and biomarkers defined. Okay, so epileptogenesis isn't just about random electrical misfires. It's actually deeply tied to neuronal damage, gliosis, and a surge of pro-inflammatory cytokines, things like interleukin-1 beta and TNF-alpha. And tracking all of this starts with CRP, or C-reactive protein. Think of CRP as a major acute phase protein made mostly in the liver. It spikes when the central nervous system takes a hit from inflammatory and cytotoxic damage. In dogs, CRP shows one of the most dramatic increases during systemic inflammation, making it an insanely valuable, even if nonspecific, biomarker for early immune responses. Next up is the NLR. That's the Neutrophil-to-Lymphocyte Ratio. This gives us a much more nuanced look at the immune response than just staring at isolated neutrophil or lymphocyte counts. It reflects systemic inflammation and zeroes in on neutrophil-mediated immune responses. And why do we care? Because those responses have been directly linked to hyperexcitable neuronal cells and microglial activation during a seizure. And finally, we have PLR, the Platelet-to-Lymphocyte Ratio. This is a super accurate hematologic index and a really exciting emerging biomarker. As you're going to see in just a second, it's proving to be ridiculously good at telling apart structural issues like brain tumors or encephalitis from idiopathic cases.
Okay, part 3, CRP and NLR clinical findings.
When we dive into the data from a 2024 Veterinary Sciences study by Despair and the team, a really distinct pattern jumps out. NLR is elevated across the board in all epileptic dogs compared to healthy ones, no matter the underlying cause. But CRP? Wow, CRP is a massive red flag. It is significantly elevated in structural epilepsy cases and highly specific to dogs suffering from idiopathic cluster seizures. Let's break that down a bit more. Dogs with structural epilepsy have way higher neutrophil counts, which drives up that NLR. Now, for idiopathic dogs, the ones dealing with cluster seizures show statistically higher CRP values than those having isolated single seizures. That tells us that severe inflammation is fundamentally driving those ongoing, self-sustaining seizures. Oh, and a quick side note. While dogs with reactive epilepsy might sometimes have high CRP, it's usually because of their primary metabolic issue, like hepatic encephalopathy or a pyometra, not the seizure itself. And hey, file this away for your board exams. Lymphocyte counts alone showed absolutely no significant differences among the groups. You have to use the ratio. Just look at how erratic the CRP distribution is in the structural epilepsy group, right in the middle there, especially compared to your standard idiopathic or reactive cases. Literally half of the dogs with structural epilepsy had abnormal CRP concentrations. This perfectly visualizes why a high CRP should make your alarm bells ring for an underlying structural lesion or an impending cluster seizure. Part 4, PLR for idiopathic epilepsy. Now, I want to shine a massive spotlight on this incredible 2026 article from the Journal of Veterinary Internal Medicine by Wang and colleagues. For you vet students, this paper is an absolute game changer. It firmly solidifies the platelet-to-lymphocyte ratio's diagnostic power in dogs, proving it actually has the highest diagnostic performance out of all the evaluated hematologic indices. When we look at the median PLR values from Wang's study, we see this fascinating staircase effect. Healthy dogs, they sit around a median PLR of 95. Dogs with idiopathic epilepsy jump way up to 132. But dogs with structural brain diseases, like meningoencephalitis of unknown etiology or MUE, they completely skyrocket past 240. And brain tumor patients, they show very similar massive spikes. So this gives us concrete clinical cutoffs, which is exactly the kind of stuff you need when you're actually out on the clinic floor. If a dog presents with seizures and their PLR is over 111, that strongly points to idiopathic epilepsy rather than just a healthy baseline. But here's the kicker. If that PLR crosses 178, you need to strongly suspect structural epilepsy over idiopathic. With an almost 85% sensitivity for telling the two apart, this one simple ratio helps you instantly prioritize which patients desperately need to get an MRI. All right, part 5, shaping therapeutic choices. Okay, so what does this mean for the patient sitting on your exam table right now? Here is your clinical pearl, and honestly, probably the biggest takeaway from this entire explainer for your future practice. The data shows both NLR and CRP skyrocket in cluster patients. So if an owner tells you their dog just had a single isolated seizure, but your in-house blood work comes back with high CRP and high NLR, do not send that dog home. I repeat, treat them as a cluster seizure patient. You need to hospitalize them for at least 48 hours. Why? Because owners miss seizures at home all the time. That dog is at an incredibly high risk for non-documented cluster seizures, and they need strict veterinary monitoring to prevent a full-blown, life-threatening neurological emergency.
Finally, Part 6, References and Key Takeaways.
Here are the key peer-reviewed articles we've been referencing. You've got the super comprehensive 2024 evaluation of CRP and NLR by DESPA and team, that pivotal 2026 Wang study that mapped out the PLR cutoffs, and the vital AKC data on drug resistance. I highly recommend pulling these up and giving them a read to really grasp the nuances of epileptogenesis and blood-brain barrier breakdown. And that leaves us with a really fascinating thought to chew on as we wrap up. If simple, cheap blood ratios, stuff we pull from a routine CBC and chemistry panel, can predict severe neuroinflammation and distinguish structural from idiopathic disease, well, are we on the verge of being able to entirely predict and prevent status epilepticus before it even happens? As you step into your veterinary careers, just remember, the answers aren't always hiding inside an MRI machine. Sometimes they're right there in the blood. Thanks so much for joining me on this explainer, and keep asking those big questions.